Chapter 12, we are talking about the shoulder girdle. So the shoulder girdle versus the shoulder joint. The shoulder girdle is made up of the sternum, the clavicle, the scapula, the sternoclavicular joint, acromioclavicular joint, and scapulothoracic joint. So our shoulder girdle is what attaches our upper extremity to our axial skeleton. Comparing that to the shoulder or the glenohumeral joint, where we're looking at just the articulation between the glenoid fossa of the scapula and the head of the humerus. We have to have movements working together between the shoulder girdle and the shoulder to get overhead motion. Motions at each are interrelated. So if we look at the picture of our shoulder girdle here, we have our sternum in the middle. Our clavicle attaches to our sternum at the sternoclavicular joint, runs laterally to attach to our scapula at the acromioclavicular joint, meeting with the acromion process. And then the scapula has the articulation with the posterior rib cage at the scapulothoracic articulation. We can see our glenohumeral joint is more lateral and distal to our shoulder girdle. When we talk about motions of the shoulder girdle, we are looking at motion of the scapula. So we look at elevation being scapula moving superiorly, so think of that as our shoulder shrugs. Depression is the scapula moving inferiorly, so that's where we tell the patient to draw their shoulder blades down. Protraction is the scapula moving away from the vertebral column, so we have a lateral movement of the scapula. Remember, serratus anterior is going to be most responsible for that motion. Retraction is the scapula moves towards the vertebral column, so that's when we have our patients draw their shoulder blades together. Upward rotation is rotation of the inferior angle of the scapula laterally and superiorly. So the upward rotation is going to look like a clockwise rotation on the left scapula and a counterclockwise rotation on the right scapula when you're observing from the posterior aspect. We also have downward rotation, which is rotation of the inferior angle medially and inferiorly. And if you look at the bottom of the slide, I have drawn a lovely picture of downward rotation. If this is the posterior of our patient, and those are the scapulae in an upwardly rotated position because of an overhead reach, downward rotation would be where those inferior angles are going to move medially and inferiorly. My arrows might not be the most aesthetically pleasing, but it was the best picture I could do. We also have scapular tilt, which is rotation of the inferior angle posteriorly. So that's where we think of the top part of the scapula tipping forward and the bottom part tipping backwards. And then scapular winging is movement of the medial border posteriorly, and that's when we can get our fingers in underneath of the patient's scapula because there's gapping in that scapulothoracic articulation because of serratus anterior weakness. These pictures are probably a little bit better than my drawing, but we've got elevation depression where the scapula moves up and down, protraction retraction where the scapula moves medially and laterally, upward rotation and downward rotation where we have the movement of the inferior angle either medially or laterally, and then we have scapular tilt where the superior aspect of the scapula tips forward. In a patient who does not have any adaptive shortening of the musculature and the scapula sits in the appropriate anatomical position, it should rest between the second and seventh ribs. So my superior angle is going to hit at the second rib and my inferior angle is going to hit at the seventh rib. Because our ribs are rounded and our scapula lays along our ribs, we don't have our scapula sitting completely in the frontal plane. They sit, or your scapula each sit 30 degrees forward of the frontal plane, and so that's what we call the plane of scaption. So 30 degrees anterior to the frontal plane is going to be our plane of scaption, and that's the angle that is in line with the scapular positioning on the rib cage. We talked about how we can't have complete overhead motion without appropriate movements at both the glenohumeral joint and the shoulder girdle, and this is what we refer to as scapulohumeral rhythm. Scapulohumeral rhythm is the relationship of the shoulder girdle and glenohumeral joint movements. So full range of motion of the shoulder joint motion requires motion of the shoulder girdle. The first 30 degrees of shoulder abduction comes completely at the glenohumeral joint. That's the only place motion is occurring as the humeral head is moving inside the glenoid fossa. But after that first 30 degrees, for every 2 degrees of shoulder abduction, we have to have 1 degree of upward rotation of the scapula. This 2-to-1 ratio is what we call the scapulohumeral rhythm, and it allows us to have appropriate positioning for the musculature and the bony support. So it assists in maintaining a functional length tension in the abductor muscles. So as the insertion of the humerus moves closer to the origin on the scapula rotates away, moving the origin farther away to prevent active insufficiency in our shoulder abductor muscles. This also helps provide better positioning to allow the glenoid fossa to support the humeral head. And we'll see on the next slide. The scapular upward rotation avoids contact of the greater tubercle of the humerus with the acromion process, keeping those bony prominences from causing impingement of the rotator cuff muscles, while also keeping the bony prominences from creating a hard end feel and creating greater range of motion in the shoulder. There are smaller arthrokinematic motions within the glenohumeral joint that are required as the humeral head rotates within the shallow glenoid fossa, and that's because the humeral head is so much bigger than the glenoid fossa, and that's why we also have the labrum that surrounds the glenoid fossa to help deepen that and promote better articulation. Looking at our landmarks of the scapula, our vertebral border is going to be the border of our scapula that lies closest to our vertebra, and so that's going to be our more medial aspect of our scapula. Our coracoid process protrudes anteriorly just above your clavicle, and we can palpate that in class. The acromion process is something that you guys should all be familiar with and know where to palpate that on the lateral aspect of the scapula. The glenoid fossa sits just below that, creating the articulation for the humeral head. The axillary border of the scapula is going to be our border that is closest to the axilla, or the armpit, and so that's going to be our lateral border of the scapula. Our inferior angle is going to be our most inferior point of our scapula, and our superior angle is going to be the angle at the superior aspect on the medial portion of the scapula, away from the glenoid fossa. Looking at our clavicle, we have a sternal end that articulates with the sternum, and the acromial end that articulates with the acromion. And you can see the scapula has kind of this hook or S shape to it that helps promote the appropriate bone movements that we need for overhead motion. With these bones and all of these articulations, we have joints. The first of those that we're going to talk about is going to be the sternoclavicular joint. So this is going to be the articulation between the manubrium of the sternum and the medial end of the clavicle. It is a synovial joint, and it serves as the only attachment of the upper extremity to the axial skeleton. So our sternoclavicular joint is pretty important. It functions as a triaxial joint, meaning that it has motion in 3 planes. There's little osteokinematic motion that happens at the sternoclavicular joint, but it produces significant movement of the scapula due to the length of the lever arm of the clavicle. So when an object moves in an angular manner, the path of the points on the object describe the arc of the motion. So we can understand this a little bit clearer with looking at the arc of motion for the upper extremity. If I put my finger on my biceps and I follow that arc as I raise my arm up overhead, that arc is going to be smaller than if I put my finger on my wrist and I follow that arc as I move my upper extremity overhead. So the closer to the point of rotation, the less motion we have. The farther from the point of rotation, the more motion we have. And that's how the sternoclavicular joint utilizes small motions to create greater movement of the scapula, which allows for more overhead motion. So points close to the axis move through a small arc, points farthest away from the axis move through larger arcs of motion. The characteristics of the sternoclavicular joint, looking at the closed pack position, so this is the position where we have the most bony approximation. That's going to be with the shoulder in full abduction and external rotation. The loose pack position, where we have the biggest gapping and greatest joint space, is going to be 30 degrees of horizontal abduction and 30 to 60 degrees of flexion. We should experience a firm end feel for all directions of movement at the sternoclavicular joint. And the capsular pattern, so if we have restrictions within the capsule, the pattern of movement loss happens is we lose external rotation more than we lose abduction, more than we lose internal rotation, and we also lose external rotation first, then abduction, then internal rotation. Movements that happen at the sternoclavicular joint include elevation and depression in the frontal plane about a sagittal axis. So if you palpate your scapula and you you palpate your clavicle and you elevate your scapula, you can feel the elevation and the depression in the frontal plane of your clavicle. Protraction and retraction in the horizontal plane about a vertical axis. So same thing, scapular movement is going to help us be able to see clavicular movement. So if you retract your scapula, you can feel the lateral end of your clavicle go posterior and the medial end of your clavicle push anterior, and that's going to be our our retraction in the horizontal plane. And then if you protract your scapula and slide it out more laterally, you can feel the medial end of your scapula shift posterior, while the medial end of your clavicle shift posterior, while the lateral end of your clavicle shifts anterior. Rotation happens in a sagittal plane about a frontal axis. So again, palpating your clavicle, if you move your arm into shoulder flexion, you can feel it rotate as it spins backwards. The sternoclavicular joint only has the clavicle move as part of the sternoclavicular joint. There's no movement of the sternum that moves the sternoclavicular joint. Because the sternoclavicular joint is a synovial joint, it has a joint capsule and an articular disc that serves for shock absorption and helps to divide the joint into upper and lower portions. The concave-convex joint with arthrokinematic motions of roll and glide that are going to follow our same roll and glide from all of our other joints. Ligaments of the sternoclavicular joint include the sternoclavicular ligament that connects the sternum to the clavicle. A lot of ligaments that we're going to discuss throughout this entire book are going to be named by where they are located, and so that is going to be a way for you to help remember them. So sternoclavicular connects the sternum to the clavicle. The posterior sternoclavicular ligament is on the posterior aspect, and it limits anterior motion of the clavicle during scapular retraction. And the anterior sternoclavicular ligament is on the anterior aspect, and it helps to limit posterior motion of the clavicle during scapular protraction. Our costoclavicular ligament goes from our ribs to our clavicle. That's why it's costoclavicular. Short, flat, and rhomboid shape. Goes from the inferior surface of the clavicle to the superior surface of the costal cartilage and first rib and helps to limit elevation. Our interclavicular ligament connects our clavicles. It's located superiorly on the manubrium, connects the superior medial ends of the clavicle, and helps to limit depression. Moving on to our acromioclavicular joint, or our AC joint. This is the articulation between the acromion of the scapula and the lateral end of the clavicle. It is also a synovial joint, but it is a plane joint, which means there is very minimal motion that occurs there. The acromioclavicular ligament connects the lateral end of the clavicle of the acromion to the scapula. We've got the superior acromioclavicular ligament and the inferior acromioclavicular ligament, which run where they are directionally placed. So the superior is going to be located on the superior aspect of the joint. The inferior is going to be located on the inferior aspect of the joint. Then we have our coracoclavicular ligament, coraco being our coracoid process and clavicular being clavicle, so running from the superior surface of the coracoid process to the inferior lateral end of the clavicle, and this ligament helps to limit posterior motion and rotation of the scapula. Our coracoacromial ligament, so coraco being coracoid process, acromial being acromion process, creates the roof over the head of the humerus. It connects the lateral superior surface of the coracoid process and the inferior surface of the acromion process. It protects the head of the humerus by limiting superior motion of the humeral head when an upward force is transmitted along the humerus. So think about falling on an outstretched hand, where an upward force can be transmitted through the humerus that would send the humeral head moving upward into the acromion. The coracoacromial ligament acts as a roof to help prevent that superior displacement. Looking at this picture, we can see running from our clavicle to our coracoid process is going to be our coracoclavicular ligament. And we have our acromioclavicular ligaments that connect our acromion and our clavicle. And then our coracoacromial ligament running from our coracoid process to our acromion, seeing it runs over top of the glenoid fossa. If we imagine the humeral head sitting in there, we can see how that one serves as a roof for the humeral head. This is again looking at the same ligaments, but also highlighting the labrum surrounding the glenoid fossa, which helps to deepen that cavity and promote better joint articulation. Let's dive into the muscles. So our trapezius muscle is a superficial muscle that lays on the back. It functionally is divided into the upper trapezius, middle trapezius, and lower trapezius. The upper trap originates on the external occipital protuberance, the superior nuchal line, the spinal process of the cervical vertebra via the nuchal ligament. It inserts on the lateral third of the clavicle and the acromion process, and it causes the action of scapular elevation, upward rotation, and retraction. And when the scapula is fixed, it causes capital and cervical extension and lateral flexion. It's innervated by the spinal accessory nerve. Our middle trap originates on the spinous process of C7 through T3 via the supraspinal ligament. It inserts on the medial aspect of the acromion and the spine of the scapula. Its action is scapular retraction and upward rotation, and it is innervated by the spinal accessory nerve. The lower trap originates on the spinous processes of T4 through T12 via the supraspinal ligament. It inserts on the base of the spine of the scapula. It acts to perform scapular depression, upward rotation, and retraction, and it is innervated by the spinal accessory nerve. Levator scapula sits just deep to the upper trap muscle. It originates on the transverse processes of C1 through C4 and inserts on the vertebral border of the scapula between the superior angle and the spine of the scapula. It acts to cause scapular elevation and downward rotation, and when the scapula is fixed, it causes lateral flexion of the cervical spine. It's innervated by the third and fourth cervical nerves and the dorsal scapular nerve. So why would levator scapula contribute to downward rotation while upper trap contributes to upward rotation? And for that, we have to look at the insertion points because their origins come from a similar place, but upper trap attaches more laterally on the scapula. And so it's going to cause upward rotation because as it pulls in its line of pull, it will cause the inferior angle to move more laterally. But levator scapula, because it attaches more medially on the scapula at the superior angle, between the superior angle and the spine of the scapula at the vertebral border, its line of pull is going to be a more direct upward motion, and so that will cause the inferior angle to move more medially. Our rhomboids sit just deep to our middle trap. They originate on the spinous processes of C7 through T5 via the nuchal and supraspinal ligaments. They insert on the vertebral border of the scapula between the inferior angle and the base of the spine of the scapula. They serve to cause scapular retraction, elevation, and downward rotation, and they're innervated by the dorsal scapular nerve. Serratus anterior is named for the direction that the muscle fibers run, as well as the serrated edge that we can see as they insert on the ribs. Weakness in serratus anterior leads to scapular winging because of how it attaches on the anterior aspect of the scapula to help hold the scapula close to the rib cage. Serratus anterior originates on the lateral surface of the first through eighth ribs and inserts on the vertebral border of the scapula and the anterior surface of the scapula. It causes scapular protraction and upward rotation, elevation of the thoracic cage when the shoulder girdle is stabilized, so when the scapula is fixed, it elevates the thoracic cage, and is an accessory muscle of respiration for inhalation. Serratus anterior is innervated by the long thoracic nerve. Pec minor comes from the ribs to run to the coracoid process. So we originate on the anterior surface, the third through fifth ribs, to insert on the coracoid process of the scapula. It causes scapular depression, protraction, downward rotation, and anterior tilt. When the scapula is fixed, it causes elevation of the thoracic cage, and it is also an accessory muscle of respiration for inhalation. It is innervated by the medial pectoral nerve. Looking at the posterior shoulder girdle, so on the left side we have our more superficial muscles and we can see our trapezius overlaying everything. If we were to peel our trapezius back, we have our levator scapula just deep to that and the upper portion, and then our rhomboids in the middle portion just deep to our trapezius. And then our serratus anterior sits more on the anterior side, coming from the ribs to attach the anterior aspect of the scapula. We also have some of our shoulder girdle muscles highlighted here, but we want to look at the shoulder joint muscles here, but we want to look at the darker shoulder girdle muscles, and we can see that all of these muscles have their origin on the trunk. And so we create, because the only bony attachment for the shoulder girdle is the sternoclavicular joint to the trunk, we use muscular support for shoulder girdle stability as well. Looking at the muscles of the anterior shoulder, We can see serratus anterior coming from those ribs to go back to the anterior aspect of the scapula, and then we can see our pec minor coming from the ribs to the coracoid process of the scapula. Serratus anterior can also be viewed or palpated laterally as it comes from the anterior aspect around to, or from the ribs around to the anterior aspect of the scapula. It has to cross the lateral aspect of the body. We talked about force couples when we went through the chapter on biomechanics, and if you remember, force couples have to have at least two forces pushing in opposing directions that cause a rotary motion. And that's what we see with upward and downward rotation of the scapula, is that we have forces from three different muscles pulling in opposing directions to cause that rotation around a central pivot point. So for scapular upward rotation, where we see the inferior angle move laterally and superior, this is going to require a force couple between upper trap pulling the lateral aspect of the superior clavicle up and medial, or superior and medial. Then we have our lower trap pulling from approximately the level of the spine of the scapula down to help rotate that inferior angle. And then serratus anterior helps pull from the front to create that upward rotation. If we compare that then with downward rotation, so scapular downward rotation is going to be where we have our inferior angle moving more medially and inferior. And this requires a force couple between the levator scapula pulling that medial portion of the superior scapula up, the rhomboids pulling the medial edge of or our vertebral border of the scapula in, and then our pec minor helping to cause the coracoid process to pull down. And so this creates that downward rotation effect. We talked about how several of our shoulder girdle muscles have an action for when the scapula moves, and they have an action for when the scapula is fixed. And we look at therapeutically reasons for having the scapula fixed where we would need that thoracic elevation are going to be for crutch walking. So when we weight bear through our hands on crutches, we are stabilizing the scapula so that it does not depress when we get lower trap activation, and it does not tilt when we get pec minor activation. Instead, we get thoracic cage elevation that helps to lift the body, as well as with activation of the lats to help lift the pelvis for non-weight bearing purposes to swing through on crutch walking. When talking about the shoulder girdle, common pathologies that we may see in therapy include separation of the AC joint. So when somebody talks about colloquially they have a separated shoulder, this is where there is spraining or tearing of the acromioclavicular ligaments, and these typically happen as a result of a fall on an outstretched arm, causing injury to the acromioclavicular and coracoclavicular ligaments that causes separation of the acromioclavicular joint. We can also look at clavicular fractures, which are going to be the most common among children. Remember that the clavicle is the first bone to ossify, and so it doesn't have the same elasticity and flexibility that the other bones do while children are growing, and so clavicles are more likely to fracture during childhood than they are as you progress through adulthood, and all of your bones have the same level of ossification and rigidity. And then winging of the scapula is going to be, again, more common in our pediatric population, but not exclusive to our pediatric population. And it is caused as a result of weakness to the serratus anterior muscle. And we can see a picture of scapular winging here where we have that vertebral border of the scapula sticking out away from the body on the right side compared to the left where the scapula sits flush with the rib cage. So before class, I want you to review the anatomy of the shoulder girdle so you can understand what will be manual muscle testing in class. We're not going to deal with range of motion of the shoulder girdle. We will deal with range of motion when we get into the shoulder joint. Write down any questions you have on this lecture to discuss in class before beginning the lab activity, and make sure that you prepare lab-appropriate clothing that will allow for exposure of the shoulder girdle.